Welcome, everybody. I'm so glad to welcome you today to our webinar on evaluating hands-on physical skills in health professions education. My name is Sarah Keith, and I'm happy to welcome you today to this Lecturio webinar. All right, so our webinar today is evaluating hands-on physical skills in health professions education. And this is our webinar series team. It takes a team to put on these events for you. And I just want to say thank you to everybody who contributed here at Lecturio. All right, this webinar is hosted by Lecturio. If you would like to learn more about Lecturio, the Lecturio platform, and our suite of educational products, you can use that QR code on your screen, or we'll place a link in the chat that you can use to find out more. I'm your host. My name is Sarah Keith. I'm the head of learning and academic strategy here at Lecturio, and I'd like to welcome you here today. Thanks for joining us. Our speaker today is Dr. Sheldon Yao. He is the chair of the Department of Osteopathic Manipulative Medicine at the New York Institute of Technology, College of Osteopathic Medicine, and the president-elect of the American Academy of Osteopathy. So, Dr. Yao, welcome, and I will hand it over to you.
Thank you, Sarah. Thank you for this opportunity to present and speak to everybody here. I guess then start in the beginning. Sorry. So I do have some disclosures. I am employed by NYIT, as Sarah mentioned. I also do work 1 day a week at St. Barnabas Hospital in the Bronx with their O&M residence. And so I do have experience teaching medical students at the College of Osteopathic Medicine here in New York, and with the residency level teaching for those training in osteopathic neuromusculoskeletal medicine as a specialty. I do hold different professional roles, including affiliations with the MBOME, ABO and MM, and the American Academy of Osteopathy. And I am the president-elect of the American Academy of Osteopathy. I do want to state that the views expressed today are my own and do not necessarily reflect positions of NICOM or NYTCOM, St. Barnabas, or other affiliated organizations.
I just want to let you know that we are not seeing your slides yet.
Oh,
So don't mind taking a moment to share those.
let me try to stop share and reshare again.
Just so they can see the slides. Fantastic. Okay.
Oh,
Thank you.
they did? Wait. Yes, slides are good?
Yes.
Okay.
Now as well. Thank you so much.
Okay. So today, I'm going to talk a little bit about some of the challenges that in my academic career I have come across with trying to assess hands-on physical skills. Even though my specialty and field is in osteopathic manipulation, I think a lot of this translates to general health professions physical skills assessments. Talk a little bit about the different rating scales that we use. I'm going to kind of expand a little bit about how we utilize OMM assessments and how that translates to looking at physical and clinical skills evaluations. I'll talk about how we could improve our assessments, and then a little bit about how new technology and AI could help with supporting these assessments. So a little bit about myself. I did graduate from NYIT College of Osteopathic Manipulation. I did train in family medicine and also did a 1-year fellowship in neuromusculoskeletal medicine. So I am dual board certified. I did, after graduating, join the OMM department in 2006. So I've been in academics for about 20 years and have been serving as the department chair since 20. And so my role here at the school involves teaching, patient care, and research, trying to ultimately graduate students who are competent and confident physicians in practice. More recently, the last couple of years, I did join St. Barnabas Hospital to help with teaching residency level training in their O&M residency program. And there, I've gained experience with looking at how we assess and promote residents throughout their training, which helped me to kind of put this together. And I do speak upon that a little bit towards the end of the presentation. So for those not familiar with osteopathic manipulative medicine, it is a hands-on philosophy where we utilize our hands to diagnose structural um, and physical restrictions, somatic dysfunctions in the patient's body that may play a part with their health. Um, in our curriculum, we integrate this fully throughout our education. We're trying to teach our students how to use that special lens of diagnosing um, physical problems that may be influencing the patient's health. We want our students to utilize the approach and not just learn a series of techniques. And that's challenging because we want them to ultimately have the goal of being a independent practitioner, being able to utilize OMT within the care of their patients, no matter what field they go into. And so osteopathic manipulative medicine is an approach that really helps to enhance the student's ability to observe, palpate, communicate, and integrate these skills into their clinical approach. So osteopathic medical education encompasses a lot of different aspects. And this diagram I borrowed from our School of Osteopathic Medicine in New Jersey. And they talk about how there are different competencies that we want our students to graduate with. And so when we break down what we are trying to gauge with our students, we want them to be competent in patient care and being able to apply these principles by first having that medical knowledge and then being able to apply these principles and practice of osteopathic manipulation on their patients. And it really has to go through a series of milestones for them to get there. And so what do we rate and grade competency with? So we have to look at their skill level, their reasoning, tie in their professionalism and safety as to when they're applying these techniques and skills with patient care. So one of the things that I have personally found as a parallel, right? We're talking about medical education, but I have a 16-year-old in the household, and he just recently got his learner's permit, right? And so it's very similar in terms of stages to progression to becoming licensed to drive a car, right? And so um, here's an image of my son when he was in Disney. And so you first learn the knowledge about driving a car, right? And then you then have to take a test to gain the knowledge to then be given the permission to learn how to drive a car. And so the learner permit exam will teach you, hey, if you see a octagon red says the word stop in it, you have to come to a full stop before you get to the sign, look both ways before you progress, right? So you learn all this material, and then you have to go out on the road, and then you have ideally a driver instructor who's next to you that also has a brake pedal, so that if you fail to yield or stop at the stop sign, that driver instructor could stop the car for you, so you don't run the stop sign, right? So there's multiple steps to eventually getting your license, passing the test, and being able to drive independently. And so one of the things that I found interesting is I was talking to my son and he's taking these driver ed lessons. And I said, when are they going to take you on the highway? And he said, well, they don't take us on the highway. And I'm like, why not? Isn't that part of driving? Don't you have to eventually get on a highway and drive more than 55 miles per hour somewhere? And so interestingly enough, I remember taking the driver test for myself. I didn't get on the highway for the exam. And so there in lies the point of this slide is talking about how our assessments will support and drive content in what they study, right? And so, or also the limitations of our assessments. Our assessments could only gain so much in terms of what we're testing after the driver receives your license, you're hoping that they're going to eventually gain the confidence, practice, and merge onto the highway going eventually 55 miles per hour. But the test itself is not assessing them while they're on the highway. Very similarly, as we kind of look at our assessments for medical school, health professions, right? We're hoping that the content, the information, the curriculum that we're giving our students, that's going to kind of come in, become knowledge, and then they're going to be able to apply that knowledge and eventually go out there and practice. And although we can't assess them on every single aspect of that practice, there are certain milestones and things that we want to make sure they're able to do. And so part of our assessment is really understanding what's important in our content, right? So our educational outcomes will kind of inform the curricular designs and then eventually the assessments. How we teach should reflect how we test, right? I'm not going to give a new driver the test to kind of merge onto the on-ramp, right? But we do want to keep in mind what is the end goal of what we want our students to accomplish. So a little bit of what I want to talk about isn't necessarily only the assessment, but actually how we teach, because that takes a big part of how we assess. So this goes back a little bit more into how our students learn. And so when we deliver information and we want our students to learn, we have to understand that there's only a certain amount of information that our students could keep in mind and pick up. And that's their kind of like working knowledge, right? Their kind of space, this working memory. Most of the time, this working memory can't exceed like 4 to 7 items. So there's this bottleneck of I have all this information, and then I need the student to kind of pay attention for this to then go into their long-term memory that they understand and pay attention. And there's certain things that we could do as educators to try to limit the distractions, right? So there could be, intrinsic load, extrinsic load, and then germane load, right? So there's different factors as to what type of cognitive load is being given to the student. And intrinsic load is something that we could kind of control. It's the content that we want them to learn. And as educators, we need to make sure that they're in bite-sized, kind of digestible information as opposed to being overloaded with too much. How much could they grasp in that one session that we have? And so here at NYT, we have an hour and 50-minute lab, which is hands-on. They're partnered with another partner and they learn the material and they have to practice that material. We could chunk in 20 techniques, but we know from experience that trying to teach 20 techniques to students based on their stage and education is near impossible. So we pretty much have a cap or max of like 5 techniques that we will kind of teach in each lab. So intrinsic load is trying to control how much information is being given to the students. Extrinsic or extraneous load is things that distract from the student learning, right? Whether it be a poor presentation, too wordy, if it's conflicting information, if there is distractors preventing the students from studying at that time. So those are things that we need to try to minimize as faculty to prevent students from being distracted as they're trying to learn. One of the things that we try to do is to make sure that we have the students come in prepared. So it's kind of like when you have to come in prepared for a chemistry lab. You don't just show up and say, okay, what experiment are we doing today, right? So you have to come in prepared. We have our material posted a week ahead of time. We have our videos of the techniques they're going to learn posted ahead of time so they could review it. And so it's not their first pass when they come to lab. They've seen it, they've read about it, they understand the knowledge about the lab. And this way, we also have handouts so that everyone is learning the same thing. We're not giving them multiple resources to learn from because there could be variations in some of the techniques and approaches that we're teaching. Finally, we want to try to promote learning. We want to promote students' hands-on practice for things to stick. And so it's important to kind of balance these things and consider the content that we're teaching, because then that's going to then drive your assessment. You can only assess on what you're teaching. And when you're able to focus and emphasize what is important for them to really grasp from there, that's going to help prepare them to prepare well for the assessment. So the clearer you are with stating these are what we want to accomplish, the better your assessments will come. So we want to tailor our curriculum, our assessments based on our learner. One thing that I have found with training and now training residents is that there are different amounts of oversight you need to provide. And so when we have first year beginning students who don't even know where their humerus is, right? They need higher guidance, more hand over hand placement, more confirmation that they are palpating and where they're supposed to be. Because they don't really have that anatomy down yet. They don't really understand even, planes of motion and how to contact and touch and palpate somebody and how much pressure to use. That all kind of comes over time and practice. And so beginners kind of require high guidance, but you have to be careful with how much guidance, because there is what's called reversal of effectiveness, that if you give too much guidance to more advanced learners, where you're kind of hovering and staying over them and correcting them all the time and not giving them the chance to kind of play with things and learn. I see that more with my more advanced students. I try to give that freedom to my third and fourth year students that are rotating with me in the clinic. I let them kind of figure things out a little more for them to realize, hey, something doesn't feel right, something feels off, or maybe there's a better way I could do this, and let them kind of learn through the experience. Because if you don't give them a chance to realize that something feels off, then they're not going to kind of self-reflect and self-correct. And so with our advanced learners, maybe they don't need as much hand-holding and over guidance, right? And you take a step back and let them learn and kind of learn by trial, right? So in terms of assessments, the assessments also have to reflect that level of examination. So with our beginners, maybe we're testing landmarks and where your hand should be placed and diagnosis, whereas more advanced learners, their assessments might be more of a combinations, multi-step, multi-level type of task as they start to gain more proficiency in the different tasks that we're looking to assign them. So some of this I talked about. How do we decrease cognitive load in teaching? Like I said before, having videos prior to coming to the labs, having detailed handouts. Our student to faculty ratio typically is 8 students to 1 faculty. We do have TAs per pod, so we have pods of 8 students, and that drops it down to maybe 4 to 1. Like I said before, with our first year students, they need a lot more supervision. So a pod leader could kind of help with one pair while the other pair is kind of figuring things out and kind of pop back and forth. And then a TA could be there to help traditionally assist with near peer teaching, because the TAs being fellow students help to provide a different type of guidance and perhaps help them because they just more recently went through it. And they could kind of help guide them with some of the basic palpation, diagnosis, and kind of explain the nuances in a more student-friendly level. Our curriculum is designed to help focus on diagnosis and treatment of different areas, and then there's a structure to it, so it kind of repeats. So the student kind of understands, hey, this first pass through, we're going to diagnose the thoracic region, and then we're going to learn 4 different techniques for that area. We're going to learn soft tissue, we're going to learn counter strain, muscle energy technique, and then HVLA. After that block, now we're going to move to the lower back and the lumbar area and kind of do the same thing. Then we're going to do the neck, the tailbone, the pelvis, the shoulder, elbow, wrist. So there's a sequence to the curriculum. So there's a repetitiveness. So it kind of prepares the brain. Hey, I'm going to kind of go through diagnosing an area and treating it with like the same principles. I just need to learn the nuances of that region. And so, in making your curriculum have some sort of um, organization so that it makes more sense for students, that will help. And that will also help with your assessments. Now they know that for each block, after each block, my assessment is going to be diagnose that area and demonstrate the treatments that you learned for that block. However, we do try to make everything cumulative. Just because you learned about the thoracic region doesn't mean that by the end of the semester, you could just kind of forget about it. These skills build upon each other because in our curriculum, we're not going to just treat the upper back and that's it. We're going to kind of take a look in the big picture, the whole person, but we have to kind of take it in chunks, like I said before. One of the things that we also do in the classroom is to try to promote formative quizzing. And so students, they sometimes will freeze under pressure when there's a high stake practical examination. But if you kind of train them to be ready to answer questions and they know that they could make a mistake and they could learn from it, and we could actually correct them, that sort of formative quizzing, I think, helps to prepare the student for that more high stakes exam. So we try to integrate more frequent formative quizzing per session. This way, it gives the student a chance to kind of perform under pressure. Because one thing to practice and just kind of they're looking at their handout, they're doing what it's saying to do, they have someone to kind of put hands over hands. But if I quiz them and put them on the spot, hey, show me this, don't look at your handout, that's going to really put a little bit more emphasis on, do I really know this material, to the point where it's not just I know it, but I know how to do it. Okay. So there are a lot of different skills in medical education in general, and medicine is performance-based. It's not purely knowledge-based, right? And so one of the things that why we need to have these assessments is that we have to ensure that our learner is ready to go out there and interact and work and treat patients. And patient safety depends on your learner having this technical competence, right? And when they're performing, it's not only that they're performing and, fulfilling a checklist, which we'll talk about, but part of what we're trying to look at is their clinical reasoning, that they have this knowledge and now they could demonstrate that they understand and could apply that knowledge through performance. When we are assessing our patients, assessing our students, we learn that these assessments is really assessing our trust and professionalism in them. And so the more that we're able to observe them through these patient interactions, the better we could develop this sense of trust, of trusting them to then eventually seeing the patients on their own or going out there and driving the car. Okay. So in my career in teaching OMM and then assessing as a student, I went through these assessments. As a teacher, I have been involved with kind of developing curriculum and then working on how can we assess our students to determine their competency in OMM skills. And so here are some kind of key things that we look for, right? We want to make sure that they are technically accurate, right? When we say we are palpating certain areas, they're over the right landmarks, their hand placement is correct, it's not awkward, they're doing things in the right sequence, right? We're assessing their clinical reasoning. We want them to make that link between the diagnosis and their approach. We want to know that they understand this integration of osteopathic medicine, the principles, and why they pick certain techniques to treat certain presentations and patients. We want to make sure that they're able to carry out these techniques and not hurting the patients, making sure the patient's comfortable, being able to explain and obtain consent for this procedure. And again, focus on safety. We want to make sure that no one would be hurt from these treatments. So there are a lot of different methods in the health professions to help examine and assess proficiency and competency. I'm sure many of you are familiar with OSCEs, but if you're not, OSCEs are usually the students have an opportunity to work in a patient encounter with an actor or actress in a clinical setting, and usually they're given a case. The actor or actress will act that out, or they will be asked to perform certain aspects of a physical exam. We also have structured practical exams. Like I said, after our blocks, we have practical exams where we pretty much tell the students, this is what you have to be expected to do. We're going to select a region for you to diagnose. We're going to select a technique for you to do. In fact, we have another station. We're going to have a review technique set that might test you on something that you learned in the past. So our structured practical exams are cumulative. Standardized patient encounters are also kind of like, here we call it ICC, but a recorded encounter that physicians could kind of view how they perform in that encounter. Students are also assessed during direct observation in clinic. There's use of checklists and global rating scales during these OSCEs and standardized patient encounters. And then there's entrustable professional activities, which is also started in the residency level, but has slowly drifted into the undergraduate medical education level. So this triangle is Miller's pyramid. And so this pyramid distinguishes pretty much novice level to expert. And this blue triangle up top here is ultimately what we want our learners to become and to be able to do. So pretty much the red and orange here, the base is knows is knowledge, right? So these two down here is more cognition. So this is the knowledge that our learners have to learn and know. And so this would be more like your first year student, second year student. They are gathering information, they're learning the basis, and usually they're assessed by using multiple choice questions. When we have this information, now we want to know that they know how to use that knowledge. So knows how to interpret, apply. There's a case presentation. Now they could kind of start ironing out and figuring out what we would do, but not necessarily doing it, but what would you do theoretically, right? So again, all this is cognition. Once we go into the green and blue here, we're talking about behavior. So this is demonstrating. So students showing that they're able to utilize that knowledge. So this is via simulations, OSCEs. How do they demonstrate what they have learned? And then ultimately, the blue triangle up here is doing. So this is where we expect our students, our physicians to be able to execute and do what they were taught there. So for our program here for osteopathic manipulation, I could teach the background information as to how to diagnose problems and issues in the thoracic spine. Now that they know how, right, they could now answer test questions on that. They could also have a case that integrates that and explain that. They could show us green here with our examinations, and they could show how they will diagnose the spine, give us their findings. We could kind of confirm, but ultimately what I want them is to do that examination in the clinical setting, right? And to kind of make sure that they're able to do that independently without supervision. And that's the ultimate bar of where we want our students to be able to safely apply what we're teaching them in the workplace. Back here. Okay. So how do we assess competency? And this is a question that I think every institution, almost every every organization struggles with at so many different levels, right? Because there's always a question about how we could make the best possible assessment. And so here are a couple of things that we really have to look at when we're talking about developing assessments for our students. The key one is validity, right? We want to make sure that the student is being tested and measured and assessed on what we want to measure, right? We want to make sure that the assessment is reliable. We want the results by the testers and we want I'm sorry. We want the assessment and the results to be reproducible, right? Feasibility. So this, I think, plays a large role with how we assess because there's only a certain amount of time, resources, and logistics. So here at NYT, we have a class of 300 students in the old Westbury campus. And so it's hard to kind of carve out a time for 300 students to be examined, paired individually, paired together, and tested by a individual, whereas certain assessments may benefit from having two people assess. That might help with the validity and reliability. But logistically, it's just too hard to have two testers test a pair of students because it'll be literally impossible to get through 300 students in that one day. So what are our resources? What are our times? How feasible is it to apply the assessment, the ideal assessment for our students? Educational impact of these assessments, right? How do these assessments drive learning and performance? And then fairness. We want to make sure that these assessments are fair, unbiased, and applied equally to all learners. So one of the things that we come across is when we have our department meetings, we're always kind of trying to figure out how we could improve our assessments. We have a hard time kind of putting a label on how we want to test, say, a particular technique. And what you put on your rubric is really emphasizing what you feel is most important for the students to gather. But if you leave something off the rubric, then doctors after the fact might say, hey, there wasn't a place where I could kind of really check off or deduct someone kind of handling the arm the wrong way or standing on the wrong side. So these rubrics have some inherent issues. And so one of the things that in putting together these rubrics is to really kind of make it comprehensive enough so it captures the aspects that you feel is kind of like most important with the student conducting any physical exam, right? So for the OSCEs, it might be student comes in, has a actor or actress as a patient, and they have to listen to the heart. So do they inspect the region? Do they palpate the area? Do they feel for the point of maximal impulse? Do they take the stethoscope? Do they put it on right? Do they listen to the key areas? Do they listen on both sides of the stethoscope? And then what do you find as key items that must be on that checklist for a heart exam? You kind of have to detail that on the rubric. And we actually give that sort of rubric out to our students for them to study. So they come in prepared for the examination. However, sometimes the rubric doesn't necessarily capture everything that you are looking for them to do. And so that is something that we'll kind of talk a little bit more about. We want to assess kind of like the technique, and it's hard to only, the rubrics are good for assessing technique, but it's hard to kind of assess clinical reasoning sometimes. And so I think there are positives to the rubric. Sometimes it's easy for the grader to kind of check off present, they did it, they didn't do it. However, for a rubric to be overly comprehensive, it might be 20 to 30 checkboxes, and that becomes very time intensive to try to check through. So for example, this was a published rubric, and there have been many publications on OSCEs and different rubrics and standardizing these rubrics. And what you could see is that many of them kind of talk about the positives and negatives and what you include here. So this is a sample OMM instrument. And so this rubric talks about how the patient was instructed, how they check for patient comfort, starts and continues without hesitation. So this is an interesting one that sometimes we don't see in a lot of rubrics because parts of this rubric actually captures proficiency. So it's not only a checklist of they did X, Y, and Z, but that they did it without hesitation helps to distinguish someone who might be a little bit more proficient than someone who is not, right? Comfort, selecting the right modality, correct placement, treatment location, and instructions. So there is dialogue. It is important that we assess our learners in their ability to communicate. And so it's not just a rubric that is assessing how they conduct a procedure, but that they are clear and able to instruct and communicate with their fellow patient. Amount of force, direction of force, timing, maintains communication, eye contact with the patient. Again, aspects of this rubric helps to capture some of the soft skills that sometimes rubrics might leave out. Reassessment, and then appears, practice, and competent in technique. Again, this is more of like a global rating that is thrown into the rubric here. So this was an interesting study they published. They had 5 medical schools. I'm pretty sure the article was from Germany. And so they had OSCEs where students were performing a knee exam and a shoulder exam. And they had examiners from the local institution. And then they had examiners, an outside referee come in and also grade with the same rubric. And so what they found was that there was statistically significant difference when between the local examiner and the referee, and that the local examiners graded students higher compared to the reference examiner, and overall that there was a significant difference in inter-rater reliability. And so I only point this out because it was interesting in the article that they stated that this inter-rater reliability might have been because the local examiners knew the students that they were testing. And perhaps there was a halo effect, or because they kind of saw themselves in them, that there was a bias present. And so there are a lot of different biases among raters when it comes to performance evaluation. And it's important that we are aware of it because the students are aware of it. The students already know, I don't want to go to that doctor because that doctor is a grumpy and harder grader compared to Dr. So-and-so, because that person is the easier grader and gives everybody hundreds, right? I had that when we were students, but I wasn't concerned about who I got because I was very confident with my own hands-on skills when performing. But it is something that I do want to bring to everyone's attention that if you're conducting physical exam assessments and you're using assessments, we're only human and we all have certain biases. And so we have to be careful and to be very aware of these biases when we're evaluating and assessing our learners. And so a halo effect is kind of letting a strong or positive or negative trait overly influence the overall evaluation. And so this is why when you have practical exams, when I had a high-stake practical exam, we did not have any conversation with the examiners beyond the instructions because you don't want to have this halo effect of being, cheery or just kind of negative and nervous. That will bias the grader. Like, oh, that guy's, a good dresser and he's charming. And so, he must be a good doctor. He must be, uh, must automatically communicate well with the patients, must be really good at OMM. And he obviously could do this technique well, right? So that's the halo effect. Um, Leniency bias is just kind of rating everybody as outstanding, compared to the opposite is strictness bias, rating everybody too low. There's a central tendency bias, just kind of not giving anything too high or too low, just kind of staying right in the average. There's a contrast effect. Let's say someone comes in and really just bombs the test, and then the next person comes in, just kind of performs to average, but because in comparison to the person before, the person's doing well, you just give them high scores. But in fact, their performance, instead of being weighed to objective standards, was being influenced by your prior experience grading someone who did poorly, right? So that's the contrast effect. So ideally, students want to be tested after the class clown got graded or something like that. First impression error, you let your initial judgment outweigh latter performances. And then similar to me effect, like I said before, you'll favor individuals perceived as similar to oneself or something that you've kind of gone through. So again, it's important to be aware of these biases as we're examining as a faculty and group. We talk about this, we examine our class averages. And yes, sometimes we grade 6 people, we had to fail one. It might seem like I have a very low average, but we look at that and we look at the numbers. And what's been interesting is to see how we could kind of look at that and help try to improve our scales and improve our ability to assess our students fairly. Because that is one of the number one complaints of our students, that, oh, this test is subjective, this test is biased. And honestly, any test has certain subjectivity to it. Just what I put on the rubric is already being subjective as to what I think is important. So what we try to do is to make sure at least these rubrics, how we're testing is as fair as possible. So how we could improve exam reliability, we conduct pre-examination training. So we have a meeting the week before, we have a meeting 30 minutes before the exam where we get together as a faculty, answer any question, talk about anything that might be in contrast to each other. We also have specific training sessions. We try to do this quarterly, where we will meet as a group and we have two of our student TAs go up there, or a faculty will go up there and purposefully make errors. And then we as a team will grade what we saw, and we then discuss afterwards. Oh, I took off, that they didn't do this, this, and this, because that went under setup. Oh, well, I took off this, this, and this because that went under execution, right? And then that helps us to look at our rubric. Is it capturing things? Are we looking at things? We all could spot the problem, but are we documenting it as present or not present on the rubric the right way? So it's important to have those meetings. We have a onboarding and orientation to faculty that join and test. We have this program with our TAs when they help with assessments, to have them sit with an attending and their grading also. And we're making sure that their grades, although it doesn't count towards the student grade, we then look at their averages and how close they are to the attending physician. And so we're utilizing this opportunity to help train our students. At the same time, it also trains our faculty. So we talked about this calibration sessions, and then again, train our examiners to be aware of these biases, and to try to avoid dependence on subjective impressions. One of the things that these rubrics do is to make sure that our learners hit on every spot. But we know that just because everybody hits on every single thing on the list doesn't necessarily mean that they are competent with what they're trying to do. So what could help capture that is to have a holistic rubric and integrating a holistic rubric, which is an expert just kind of looks at the performance and on a scale of like 1 to 3, I've seen 1 to 5, some sort of Likert scale could say, you know, does really well, fair, does poor, right? Overall, these holistic scales helps to capture the overall performance, and it may um, help capture things that a rubric does not pick up. So here's an example of having more of a global or holistic scale, right? And so here you'll see 1 as poor, 5 as excellent. And so on a scale of 1 to 5, it's not saying did they do every single step on a checklist, but globally, did they tick off key aspects of each for the assessment? So these global or holistic grading scales kind of help to capture maybe more competence when capturing and trying to assess clinical judgment, communication, professionalism, right? Whereas a checklist and checklist rubrics help to kind of make sure that they're able to complete the task, right? So these global scales can be utilized to really focus on, are our learners hitting on the big picture and not just hone in so specifically on doing these techniques? Because we know I could perform a technique exactly to the T, but perhaps I'm not paying attention to how quickly I move the head or how far I'm moving it or how forceful I am, or my communication with the patient is not clear and I didn't prepare them and talk about the right things. So having a global scale helps to capture some of those aspects. So some key recommendations with assessments. We want to make sure to kind of have these checklists and also have like a global type of scale. Training examiners is key for consistency and reliability. We want to ensure that examiners are aware of potential biases. One of the things that really helps is to make sure you have a clear example of what's borderline, what's failing, so that everybody in terms of faculty is on the same page of what sort of performance is that line where you draw where a student is competent or not. Because if that line varies from examiner to examiner, you already have too much variability. And so it's not reliable. So what is that line that really distinguishes a performer on your assessment as competent versus not competent? Once you have data from these exams, make sure to review and try to correct for discrepancies in grader scores, or whether it's training the SP to be clear, looking at the exam, or tinkering with the rubric to help capture what everybody needs to capture. Just quickly, with my work with the residency, there has been a move from competence to looking at entrustment, right? So entrustment is, do we trust this learner to eventually practice on their own independently, right? This is trusting them to give them the car keys and say, go to town, go on the highway. I fully trust you, right? I trust you to be a physician and apply these techniques independent of me overseeing you, because I trust you that you will not harm the patient and you'll be effective in applying what you need to do. So this image was taken from an article written by Dr. Seals, and it talks about how we kind of progress from beginner to expert level in all aspects of osteopathic manipulation. And I like how he put in beginners, you might not be really comfortable, you might forget things, you might need prompting. And as you start to get more comfortable, more seasoned with these techniques, you start to perform these techniques with more competency, where eventually you're going to be fully ready to integrate and apply and adapt, right? You might come to a situation where I'm used to doing a technique a certain way, and all of a sudden my patient can't lay on their back. They have to be seated. How do I adapt that technique to apply it in a seated position, right? So at that point, that's when you're getting more to level 4, level 5, being to adapt to what's going on. Again, here is the milestones in residency training. This is just for utilizing a technique, a direct technique, right? So a level 1 is to be able to perform it under supervision. Um, Level 2 is with indirect supervision. So I'm kind of in the room, but I'm not like over you, right? Level 3, having you identify and treat in routine patients. Level 4, more complex patients. And level 5, just they become now the mentor, right? They say, see one, do one, teach one. And when you reach that teach one level, now you've come to the point where you're able to best understand the knowledge, apply it yourself, and then teach it. So just a couple of things now with technology. There is a vast increase with the possibilities of what we could do with technology at NYIT. We have been piloting the use of VR headsets with different programs. And so we have one program where we try to integrate some of the basic things with OMM so they could practice, so they see the knowledge, not for the first time in the lab, but they've kind of seen it in a game or a simulation, right? So we all know like pilots have to undergo simulation before they fly a plane for real, right? And so can we give students a risk-free environment where they could kind of practice and mess up and not feel like there's repercussions of possibly hurting somebody, right? So it provides them a low risk environment to practice and have feedback. One of the VR programs that we have at our school is a neuroanatomy program. And so person who puts it on is in the middle of a brain, and you could slice and cut the brain however way you want so many times. Now imagine that in a neuroanatomy lab, you have one specimen. If you cut it, that's it. But here in the simulation, you could make multiple planes and cuts of the brain and look at it and learn and see it in 3D. So it gives the learner a different view of things. We're also piloting to utilize AI to give feedback on certain techniques. One of the techniques that we use is called counterstrain, and it involves placing their patients in certain positions. And if we train the AI to recognize if the position is incorrect, gross motion, you should have flexed instead of extended, you should have side bent right instead of side bending left. Can we have AI help students give feedback? Because students, when they're practicing with each other, perhaps they're practicing, but they don't know that they're not doing it right. And so can they put that in, and can this video then get some sort of feedback for AI to assist with that? Below are some other AI opportunities. AI generates standardized patients, where learners could kind of work with a AI standardized patient that might have low back pain. And so you're asking these questions, and then the AI will provide answers, and it'll go down a certain road based on what that patient actually has. And at the end, the AI tool will give them feedback as to what questions they miss, what else they could have said to better hone in on what they were talking about. I know that faculty have been using AI to help generate items, multiple choice questions to test the knowledge base, but how can we utilize AI and integrate it into providing feedback for physical exam skills? And that's, an exciting and new venture too that we're looking forward to continue to pursue. So overall, trying to improve assessment systems, we want to regularly review our data, try to identify patterns, grading variability, update rubrics based on learner performances, align assessments with what we're expecting learners to perform clinically, integrate learner feedback, and then pilot emerging technologies thoughtfully. Remember that our assessments cannot be static. It has to kind of evolve with clinical practice. In summary, clinical skills assessments have to measure performance, not just knowledge. And effective assessments will integrate technical skill, clinical reasoning, professionalism, and safety. Reliability will improve with structured rubrics, adding some global ratings to supplement that. And ultimately, competence-based education will lead to entrustment. We need to trust our students to go out there and practice. With that, I thank you for your time and attention. I'll turn it back to Sarah, and I'm happy to answer questions.
Thank you so much, Dr. Yao. That was very informative. We do have some questions that have come in, and those are coming in now. I'll start with this one. In pediatric settings where the procedures are more delicate and more high risk, how can we safely assess students without compromising patient safety?
That is a hard one because first 2 years we teach pediatric OMM. How do we apply these skills to the pediatric population and newborns? And there's really different factors. It depends on the size and group. So I'm not going to have 300 students work on babies, but I've done, and many of you probably have done, CPR for CPR classes. And for those classes, they have baby mannequins, right? So you learn to back blow and you learn to do your compressions on a mannequin, right? So first, are there models that you could practice on for peds? And I know that in our medical school, we actually have mannequin robotics. And so you could have a baby, born. We actually have a pregnant mannequin too that delivers. And so you go through these simulations. So how can you practice in a safe environment, like I said before you actually get to the real thing? On their clinical rotations, when they're with their preceptors, we ask them to get comfortable with applying and palpating and working with the kids because they're going to do a newborn exam. You're going to be palpating the kids. And so when we're talking about these procedures, part of it is getting comfortable, finding the right setting for these learners at their level with the right amount of supervision when possible.
Right, thank you. This question, is there a way to modify these evaluation techniques for residents?
So,
No,
I'm sorry.
asking.
Sorry, I didn't let you finish. Go ahead, Sarah.
No problem. Is there a way to modify these evaluation techniques to residents since there are no OSCEs or formative exams? That's the question.
So all these are published. Many of these OSCE checklists for each region for different types of patients are out there. The thing is, at the time of residency, as a program, being involved in a program, you already are doing these without a checklist. You know when they're missing something. And so that feedback comes more without a checklist. Even though they could look at their check from medical school, they should already kind of have that down as they're doing a heart exam, as they're doing a musculoskeletal exam. Is it 100% correct? They miss things. I had a patient with low back pain. The resident came out. I said, how were their reflexes? And I forgot to do it, right? You already know the checklist because as you're attending, you're going to want them to make sure they do the special test. They follow that checklist also. So do you need a checklist for residencies? You can, and you could adapt any of those out there. But I think that as preceptors in a residence, we already have those checklists because that's already what we do. Medicine used to be an apprenticeship. Medicine used to be someone hung by your side for 4 or 5 years, and then you're allowed to be called doctor. And they saw inside and out every type of case that you could have perceived and how you approached it. And then they mimicked it. It's that now medical knowledge has like expanded so much that we have to be in the classroom setting. And in the classroom setting, you don't get that kind of tie-in to the clinical world. And that's where by the time you hit residency level, they need to have that application of all that knowledge to the practice of medicine.
Excellent. So this question is a little bit more on the psychometrics side. You mentioned utilizing data. So in performance-based assessments like a physical exam, is there a recognized analog to item analysis that would help evaluate the difficulty and the discriminatory value of a specific station?
That is above my head, pay grade, but absolutely. There, once you have data, we at our school, we have a lovely statistician, and I send these things to her, and she tells me those things. We have it for our items. Luckily we have 300 students. For every test, we have 300, an N of 300 to make sure that these items are valid based on the statistics. So absolutely, there is a way. I I can't say how, but there is a way based on how you score. And eventually, if you check off everything as present or not, you have to make that cutoff as to what is a passing score out of the total of zero, they didn't do it. Yes, they kind of did it, but it wasn't great. Or yes, they fully did it, right? Zero, one, two, or whatever your rubric is, that is the challenge in designing your assessment. Because what if they did something wrong that was so horrific that they should have failed, and you would never trust them in the public if they did that one thing? So we do have a checkoff, which is automatic fail, dangerous maneuver. They did something that was totally too dangerous. And even if they did everything else right, they could not pass that station. So, yes, statistics could be run on all this data, plenty of data if you develop these rubrics and have a series of exam scores to kind of run through.
Great. And I love that answer about like bringing in subject matter experts in, psychometrics and data analysis to help support that. We do have a couple of questions about AI and how you might use AI to help assess clinical skills and hopefully reduce bias. Do you believe that using AI does help reduce bias? And have you used it for these sort of hands-on skills assessments?
So we're just starting. I think that it's going to be biased because you're feeding AI what is normal, what is the right amount, right? So one of the things that we're doing with the program is to train it to recognize in a video when someone goes too far or goes in the wrong direction. But I am telling and teaching AI to recognize when is something too far, right? So there are challenges, and I think that ultimately, can it be less biased? Sure, but I also think there could be the other extreme where that technique might have been perfectly fine going past that because of the patient habitus or because, just because they went past. So when you start making hard, um, hard restrictions as to past this is wrong, you lose the kind of like humanistic kind of flexibility as to, yeah, that would have worked. And so I do caution against depending too much on AI to utilize it. I just thought it was a novel way to try to provide feedback for students when faculty can't be there. But I don't want AI to take over my job. So yeah, AI teaching them and testing them. OMM is a hands-on skill, and I feel like, at least that's job security for me for the time being.
Excellent. Well, thank you, Dr. Yao, for all this good information and for answering questions. I know that as a practicing physician, you have a busy schedule, and I appreciate you making time for all of us today. And I don't know if you've been able to see all the kind comments in the chat, but very appreciative of this material. So thank you so much.
Thank you.
So again, if you are interested in learning more about Lecturio, we have a link there in the chat, or you can see a QR code on your screen. So that QR code is on your screen or link in the chat. We also offer Simtex, which is simulation on any device. You can do this on your desktop or mobile device with more than 200 interactive simulations of clinical procedures with step-by-step guidance and no special equipment needed. As you're thinking about how to use simulation labs, those are always a little bit limited in time, and you may not get as much lab time as you want. So this is a great way to scaffold with your students, giving them a little more practice outside of that lab time. We also have Healer. Dr. Yao mentioned the difficulty of assessing clinical reasoning. And Healer is a product that was created by the New England Journal of Medicine and is now owned by Lecturio. And you can learn a little bit more about it with the QR code on your screen or with the link in the chat. But this is a way to teach and assess clinical reasoning and to give feedback to students on their clinical reasoning process. So if you are interested in that, please use that QR code on your screen or the link in the chat, and we will get you more information about Healer. If you enjoyed this webinar, I would love to welcome you to sign up for our next webinar, which will be what from teacher-centric to learner-centric, what that really means in health professions education. So that's going to be an exciting webinar. I hope that you will join us. We have a great speaker planned for that. And then we also have a demo of some of our features, designing for durable learning, spaced repetition, and AI flashcards in healthcare education. That is on March 4th. So if you'd like to join us then, again, QR code on your screen or link in the chat and you can sign up. And we appreciate your time and we hope to see you at our next webinar.